Alice in Wonderland Syndrome is a rare perceptual neurological condition in which the brain temporarily distorts the size, distance, shape, or movement of objects, the body, or the surrounding environment. It is not a psychotic disorder. It is not imagination. It is not a metaphor. It is a measurable disturbance in sensory integration and spatial processing occurring within specific neural networks of the brain. Individuals experiencing this syndrome perceive reality as altered despite knowing, at an intellectual level, that the distortion is not objectively real. This dissociation between perception and insight is a defining feature of the condition and distinguishes it from delusional or hallucinatory disorders. Section 1. Historical Identification. The syndrome was formally described in 1955 by British neurologist John Todd, who observed a cluster of perceptual distortions in patients with migraine and epilepsy. Todd named the condition after Lewis Carroll's novel Alice's Adventures in Wonderland, as Carroll himself is believed to have experienced migraine-related perceptual disturbances that influenced his writing. The term does not imply fantasy or whimsy. It refers to specific neurological symptoms that mimic the spatial and bodily distortions described in the literary work. Since its initial description, Alice in Wonderland Syndrome has been documented in pediatric and adult neurology, though it remains underdiagnosed due to its transient nature and lack of external physical markers. Section 2. Core Perceptual Disturbances. Alice in Wonderland Syndrome primarily affects visual perception, body schema, and spatial orientation. Individuals may experience micropsia, in which objects appear smaller than they are, or macropsia, in which objects appear abnormally large. Distance perception may be altered, causing objects to seem closer or farther away than their true position. The body itself may feel distorted, with limbs perceived as elongated, shrunken, or disproportionate. These distortions occur without loss of consciousness and without impairment of intellectual function. The brain continues to process information, but the spatial mapping of sensory input becomes temporarily corrupted. Section 3. Temporal and Motion Distortion. In addition to spatial changes, many individuals experience altered perception of time and motion. Movements may appear unnaturally fast or slow, a phenomenon referred to as tachysensia or bradysensia. Time may feel accelerated or suspended, creating a sense of detachment from the external environment. These disturbances reflect dysfunction in cortical regions responsible for integrating sensory input with temporal sequencing. The experience is often described as unsettling rather than frightening, as the individual remains aware that the perception does not match reality. Section 4. Neurological Mechanisms. Neurophysiological research suggests that Alice in Wonderland Syndrome arises from transient dysfunction in the temporoparietal occipital junction, a region responsible for integrating visual, somatosensory, and spatial information. Disruption in this area interferes with the brain's internal representation of body position and environmental scale. Functional imaging studies indicate abnormal cortical excitability and altered neuronal firing patterns during episodes. These changes do not reflect structural brain damage, but rather temporary dysregulation of sensory processing pathways. Section 5. Associated Neurological Conditions. Alice in Wonderland Syndrome is most commonly associated with migraine with aura, particularly in pediatric populations. It has also been observed in temporal lobe epilepsy, viral encephalitis, especially Epstein-Barr virus infection, traumatic brain injury, and certain neuroinflammatory conditions. In rare cases, it has been linked to medication effects or withdrawal states. The syndrome itself is not considered a disease, but a symptom cluster arising from underlying neurological instability. Section 6. Distinction from psychosis. A critical clinical distinction must be made between Alice in Wonderland syndrome and psychotic disorders. Individuals experiencing this syndrome retain insight. They recognize that their perception is distorted, even if they cannot correct it. There is no fixed false belief, no loss of reality testing, and no externally generated hallucination. The disturbance lies in perceptual scaling rather than belief formation. This distinction is essential for accurate diagnosis and appropriate management. Section 7. Pediatric presentation. Alice in Wonderland syndrome is more frequently reported in children than adults, likely due to developmental differences in cortical maturation and migraine expression. Children may struggle to describe the experience, instead reporting that rooms feel too big, hands feel wrong, or objects are moving strangely. These episodes are often brief and may precede or accompany migraine headaches. In many cases, the syndrome resolves spontaneously with age. Section 8. Emotional and psychological impact. Although the condition is neurological in origin, repeated episodes can produce secondary anxiety, particularly if the individual fears loss of control or misinterpretation by others. The unpredictability of episodes may lead to hypervigilance and avoidance behaviors. Importantly, the emotional response is reactive, not causal. Anxiety does not produce the syndrome, but unmanaged fear can exacerbate distress during episodes. Section 9. Diagnostic approach. There is no single diagnostic test for Alice in Wonderland syndrome. Diagnosis is clinical, based on detailed patient history and exclusion of other neurological or psychiatric conditions. Electroencephalography may be used to assess seizure activity, while neuroimaging is typically normal. Accurate diagnosis relies on recognizing the specific pattern of perceptual distortion combined with preserved insight and episodic presentation. Treatment focuses on addressing the underlying neurological trigger rather than the perceptual symptoms themselves. In migraine-associated cases, prophylactic migraine management often reduces episode frequency. When linked to infection or epilepsy, treating the primary condition leads to resolution. The prognosis is generally favorable. Most individuals experience complete remission, and the syndrome does not progress to neurodegenerative or psychotic illness. Section 10. Final summary. Alice in Wonderland syndrome is a rare but well-documented neurological condition involving transient distortion of perception, body schema, and spatial awareness. It arises from temporary dysfunction in sensory integration networks, not from imagination or mental illness. The preservation of insight distinguishes it from psychosis and underscores its neurological basis. Although unsettling, the condition is typically benign and reversible. Alice in Wonderland syndrome demonstrates how reality, as experienced by the mind, is constructed by precise neural coordination and how fragile that construction can become under specific neurological conditions. You've just heard one more fragment of how unstable, unpredictable, and fragile the human mind really is. If this case or this disorder changed the way you look at people, that means you're finally seeing what most can't see. New files will be opened soon. More cases. More disorders. More cracks in the human psyche. Until then, stay observant. And if you want more cases, you know what to do. Remember, observation is survival.